Hello, everybody. I'm Ira Kirschenbaum. I am the editor and editor-in-chief of the Journal of Orthopedic Experience and Innovation. We have a very exciting topic this evening. This is the work of arthrotomy. This is going to be autologous culture chondrocytes with mini-arthrotomy. We have a great panel today. Um, Please remember, keep your audio on mute unless you're speaking and ask questions in the QA box at the bottom of your Zoom screen. We'll call on you and ask you to please, if you would like, ask you to please show your video and ask your questions. There'll be various times throughout the night we will be doing that. Okay. Um, Hold on. So I'd like the faculty to introduce themselves, and let's start off with Neil.
Hey everybody, thanks for joining us this evening. I'm Dr. Neil Kumar, the University of South Florida and the Florida Orthopedic Institute based out of Tampa, Florida, specialize in joint preservation and cartilage repair and restoration.
Okay, Ryan.
Yeah, again, good evening. Thank you, everybody, for showing up tonight. This is awesome to get together and talk about such a cutting edge technology and just something that we're all so passionate about. I'm Ryan Fader. I'm an orthopedic surgeon, subspecialized in preservation surgery as well, all hip arthroscopy and then sports knee preservation, cartilage restoration, et cetera, up in Minneapolis, Minnesota. And excited to be here tonight.
Excellent. And now I'm going to introduce the final panelist, Matthew Tal, who will also take over moderating after he introduces himself.
Hi guys, Matt Tallum at University of Nebraska in Omaha, and my practice, similar to Neil's, is mainly knee preservation. So honored to be a part of the panel, and it's exciting to do this. We were just talking with Dr. K about everything before, so appreciate all the interest in this. It's a topic that all three of us really are passionate about and enjoy, and we also know that it's a topic in terms of cartilage restoration that there's a lot of gray, and that whether you are well experienced or maybe just coming into practice or coming out of fellowship, that sometimes there's questions on what's the right algorithm. And particularly with MACI, there's still sometimes some mystique to that, that hopefully we can help to clarify, and certainly happy to take questions, as Dr. K said, and chat about things along the way. So hopefully this will be fairly interactive. I'm going to try to go through, let me see if I may be messing this up. Sorry. Okay, there we go. So beginning stuff here, just kind of the boilerplate stuff as far as the disclosures. This is a consultant talk in conjunction with Joey, but along with Baricel. Those of you that are on probably are at least somewhat familiar with MACI, although we can certainly discuss some of the basic premise of it if you'd like at any point. Essentially, it is an autologous chondrocyte product. So you harvest cells from a patient, two-stage process. Those cells are then grown and reimplanted in a second stage. We mentioned the rehab side of it here. That rehab guide is available either digitally or in print form. It's actually a very, very well thought out guide. So for those of you that are interested in rehab, I think it's a really valuable part of the recovery process from MACI. MACI in general, I mentioned it's autologous. It's on a scaffold. It is FDA approved for patients 18 to 55. Generally, we often kind of gloss over some of the sorry, I'm having trouble with my keyboard here. Some of the contraindications, but I think it's worth just spending a quick minute on this. This may be a little bit different than other cartilage products you would use, but it's worth at least looking back at this from time to time if you don't use a lot of MACI. Gosh, this is kind of advancing on its own. Sorry, guys. Hopefully I'm not botching this. But just to say, you want to make sure that they don't have an allergy to either gentamicin or aminoglycosides. That's something that, the medium contains that to try to prevent any bacterial growth. Any inflammatory arthritis, typically that's not going to be good for cartilage restoration in general. One of the other things that's mentioned in there is just inability or unwillingness to perform the rehab protocol or abide by the rehab protocol, which I like PT a lot. So I think that's a valuable part of this. And I will say, I think MACI really requires patients to be engaged. So it's worth thinking about that ahead of time. As far as the adverse reactions, you can see on this slide, none of these are going to be super surprising for those of you that deal with cartilage. A couple specific things down there with pregnancy, you can see noted, and then pediatrics, not FDA approved for under 18, but there is a fair amount of data in the literature and then also experience from a lot of folks around the country with a pediatric population. So can always discuss that at a later time if that's helpful for people. So let me see. Let's see if maybe we do it down here. Okay. So we'll run in through this, just a few slides to overview MACI, and then we're going to try to make it fairly case-based. So hopefully that's kind of a real-world simulation. We've intentionally picked cases for the three of us that are each a little bit different. And so we'll go through those. But just as a baseline, many of you know this already, but these cartilage defects are challenging. They do not have a lot of regenerative potential. And so that's the premise for repair historically or restoration with some of the newer products the last couple decades is to try to resurface those in a biologic friendly way, help to improve patients' pain and function, and then ideally put off metal and plastic for down the road. So we'll go on to the next one here. In terms of history of MACI, it was FDA approved in the 90s here. The first generation was Carticel. There was a second generation that still used those. That was a liquid suspension with the cells. And then the third generation, MACI, which is where we are now, was almost 10 years ago, which is kind of hard to believe. That really was a big jump, to be honest, because it made things easier and I think actually also improved the cell delivery. So the cells are actually layered in a high density, so 500,000 to 1,000,000 cells per square centimeter on this collagen membrane. It's a pig or a porcine 1,3 membrane. It's very easy to use. It's a much, much simpler technique. And so it's something where, in orthopedics, a lot of times we get excited about new technology, but you want to be mindful about, is it going to improve outcomes? Is it more efficient? Is it more efficacious? And I think this is one where really it hits all of those categories. So that was 2016. The instrumentation, which I'll show a slide on in a second here, came out in 2019. That's been very helpful for just reproducibility for a variety of different defect sizes. And then the thing that's really exciting just within the last year is the arthroscopic technique. And so we'll go over those instruments as well. Let's see. So the membrane is the same, so perhaps different than in the past when there were advances in the membrane. The membrane's the exact same. It's just the delivery system, whether you do it open or arthroscopic. And that can be really your choosing. The arthroscopic ones, you just want to be, I shouldn't say small, but relatively smaller, under 4 square centimeters. And you want it to be in an area that you can access relatively easily arthroscopically. So patella, for instance, at least I'm not aware of anybody doing that. I know there are some like Grant Garcia has done trochlea. You can certainly try it on the tibial plateau. The instrumentation is specifically designed for the femoral condyles, but you can certainly try it elsewhere as well. You can see both sets of instruments here. So I mentioned the instruments that came out, these custom cutters. You can see the variety of sizes there. They have different sizes, different shapes. The vast majority of the defects that you'll encounter are amenable to these. I still, a couple times a year, will do my own kind of custom implant if it just is not the right size or shape. But in general, these work really nicely, and it's very reproducible going from the defect to the graft. The arthroscopic instruments here, I'm not going to go through all of them one by one, other than to say a tremendous amount of time and effort was put into these. So I was very excited and fortunate to be a part of the human factor study, which was the study that happened before FDA approval for MACI Arthro. And just a ton of work and thought went into these instruments. And so they're all disposable, which is nice because they're sharp, they're very easy to use. The cutters are here, the cannulas are here, and then this V shuttle is the delivery device. Your local reps can definitely show you these. They seem very simple, but they are really quite effective when trying to do this arthroscopically. So that's kind of the overview on that. If there's any questions, by all means, pop off your mute button. I don't see anything in the chat right now here, Dr. K. So
Yep.
If anybody has questions, happy to chat about it there. Otherwise, we can kind of launch into cases.
All right, let's do the first
All right.
case.
Well, good. So we'll roll on to the case here. So this is my case first, and I'll pass it off to Neil. This is a case of a military guy. We have an Air Force base here in town. It's a case of an isolated medial femoral condyle. So I bring it up because really you can do MACI anywhere in the knee. That was when it was FDA approved in 2016. It used to be hard to do in the patellofemoral joint, or to get approved, I should say. It was FDA approved for the whole knee. So really patella, trochlea, condyles, even the plateau if you want to. Any of those are reasonable options. But this is one where for an isolated condyle, you can definitely do MACI. This actually would be a great one now to do arthroscopically if you were so inclined. So I'm not going to go through all the words here, but basically this guy had had kind of an acute injury about a year before I saw him. It was while he was deployed and overseas, felt this acute pain and pop and kind of just dealt with it by the time he got back stateside. Continued to deal with it. I saw him and he had about a year of pain at that point. You can see this was about 3 years ago now. It really was a fairly mild MRI. I'll show that to you. Did not look that bad. So I said, gosh, as much as I like cartilage surgery, I don't know that every cartilage defect needs a cartilage surgery. We tried to non-op it. We got an unloader brace. We had him do PT. We did PRP. He just unfortunately did not do that well. It wasn't bad. He just was not that happy with it. And ultimately, for what he does in the military, particularly for his duties, he had to be able to run and ruck and physical activities and just was not able to do that. So I'll go through his imaging here. You can see his alignment there. I do like to get alignment films on all cartilage patients, particularly in the tibiofemoral compartment. You can see a weight-bearing view on the AP. We do get Rosenberg as well. This is a little bit small, so I apologize for the clarity there, but you can see there's like a, kind of a high-grade partial defect in the weight-bearing surface of the medial femoral condyle there. So I did end up taking him to scope it. The initial thought was not that this would be a definite second stage MACI implant. Looked throughout the knee. He had some mild stuff like a plica and some fat pad hypertrophy, but basically the only thing that was really relevant was the medial femoral condyle defect. And it's not big, guys. I mean, you can see there it's about 1.5 centimeters in diameter, was not even quite full thickness. And so what I told him afterwards is, I think you have a really good shot to still manage this conservatively. I don't think you have to jump into anything. So you can see the picture of it here. It's not super impressive. And that's the interesting thing about cartilage is that sometimes the size and the nature of the defect doesn't necessarily correlate with the pain. So I think that is interesting here. He just unfortunately was not able to get back in terms of even just the basic training stuff, lifting, running, rucking, that same stuff that bothered him before. So we did end up going in for a second stage. As I mentioned, I think this is one now where you could certainly do this arthroscopically. It would actually be a beautiful fit for that. This was using one of the custom cutters. I certainly don't mind making an arthrotomy, as you can see here, but it can be a relatively small arthrotomy. And when you're implanting this, you really are just using fibrin glue typically. So a thin base layer of fibrin glue, the cells go down. You can put a little layer around the outside, which you may or may not need, although I still typically like to do that. And he did very well. So his surgery was about, I guess it was about 2.5 years ago now. And he was cleared around 9, 10 months, got back to running. I saw him in a year. He was doing great. It's been about 1.5 years since I've seen him. So hopefully he's still doing well. But relatively straightforward case and one where, like I said, you could do it open, you could do it arthroscopically, but just a powerful technique in terms of using the patient's own cells. So I'll pass it over to Neil. If there's questions as we're transitioning, certainly happy to address those as well.
Thanks, Matt. So this is a nice way to stack cases here because we're going to go from an isolated defect, I think something that people are probably a little more comfortable with and familiar with. And now we're going to go kind of to the opposite end of the spectrum here and talk about a case that has a lot of gray and probably not a lot of great choices and options here for us. And you can tell by the slide at the title here that we did some work on this patient here. So we'll dive right in. Oh, I guess my mouse is going a little funky.
I can move it.
There we go. So my patient's, she's 40 at the time that I saw her. She's very active, particularly when it comes to CrossFit competition and weightlifting competition. So she does travel around the state and around the country for competitive CrossFit and weightlifting. And she had, chronic pain that had been built up for quite some time. And of course, all the typical symptoms that we would expect, pain and swelling and loss of function. And and so she had actually presented to my partner here. We can go to the next slide. And overall, you can take a look at her x-rays and really no significant findings here. She was treated conservatively by him, as we would expect with the typical modalities. and unfortunately, she was unable to really get much relief. Her MRI kind of highlighted some areas. I mean, we can see in at least on the femoral condyle some changes, but overall, not anything that I would typically expect to see significant full thickness multifocal defects, as the arthroscopy photos will show here in a second. But overall, at her age and activity level, she was sent for a scope. Dance around her a little bit. Yeah, and had significant cartilage wear, much more than I would expect from that MRI. And so he did a debridement and did a biopsy, and she had a loose body, which was removed. Trying to see if a basic debridement would be able to get her back to activities, continue conservative treatment beyond that. Not really, again, with a particular goal or specific plan that we would come back with a graft. Unfortunately, she wasn't able to get back to her activity levels. A lot of pain, a lot of swelling, and just functional loss. And so at that point, he sent her to me and said, "Hey, let's see if Dr. Kumar has some tricks up his sleeve that he can try and really try to get this patient back to activity." So, at this point, this is at least in my hands, this is a case that I don't necessarily have a clear black and white set of options. We sat and talked to her for a long time about the potential options. She's 40. She's, again, very active and has multifocal significant defects. And so what to do? And ultimately, we did talk about and decide on doing a multi-compartment MACI grafting here. At that time, talk to reps at Vericel and say, "Hey, listen, we're going to need 2 grafts." And that's really important, I think, in terms of preoperative planning, is particularly if you're dealing with bigger defects or multiple defects. Ensuring that obviously that you have enough graft in order to do your repairs. And I always like to say, prevent yourself from doing a Kumar lesion and running short, and making sure that you have a backup plan. In order to access her knee, I talked to her and we ended up doing a tibial tubercle flip osteotomy. So that allowed us access to the entire knee, and as well as a little bit of anteriorization to try to offload the patellofemoral joint, because she did have bipolar lesions. So we'll kind of show you some of the surgical pictures here. So we were able to open up the knee, and she had significant defects of both condyles and bipolar lesions of the patellofemoral joint. And actually, all of these lesions were prepared, as Matt was talking about, with the cutters. So if you've not had any experience with the MACI instrumentation, the cutters really make this procedure very straightforward, very quick and easy. The learning curve is very short, and really do fit a significant variety and range of defects, including tricky surfaces, patella and trochlea. They work really well. And so for this particular patient, we actually didn't use sutures. We just used fibrin glue, and we're able to get all of the defects grafted. And so these are kind of pictures there. So the rehab booklet, excuse me, we're dancing around. It is very helpful. I use it for all of my MACI patients. It covers, including doing simultaneous surgery, such as osteotomies. It works very well across the spectrum of cartilage repair and any additional surgery you may have. Can you go to the next slide, Dr. K? And so this was her overall rehab plan. Very slow, multiple defects, tibial tubercle osteotomy. As we know, when you cut the hinge of the tibial tubercle osteotomy, it does heal a little slower. So again, it just provided additional data to move slow. Overall, we released her to non-impact exercises around 3 months, running, and around 6 to 7 months. At 1 year, she was released to do everything, including going back to her competitive CrossFit and full weightlifting and powerlifting. And she did great. Let's go to the next slide. She did really well. She's about 2.5 years out. At about 2 years or so, She was getting some discomfort from the proximal tubercle, the osteotomy screw, and just wanted to take that out. And actually at that time, she reported to me that actually her other knee was more limiting. She was really worried, not about her surgical knee, but actually her other knee breaking down and having a similar appearance on arthroscopy. So we planned to take the screw out and do a second look at her left knee. We also did scope and debride her right knee just to kind of get a sense of where she was here now, about over 2 years later. And so if we take a look at these second look pictures, and we'll kind of flip through these here, but we can see, just kind of see where she was about 2 years before, and we see really good graft fill. We see excellent contour of the grafts, and full defect fill, and with the probe, stable tissue. You can go to the next one, Dr. K, and flip through these. But really, all four surfaces have excellent fill. Even this large condylar defect, really happy with how the graft had healed. So just beyond, patient-facing outcome, but also from a surgeon standpoint of, does it work, right? How does it look? How does it hold up in this patient who has so much wear and is going to be very active on her knee and has high expectations for the performance of her knee, and really has held up well. And about 2.5 years out now, she's doing great and back to her full activity, and really, like I said, limited more by her other knee, and planning for the possibility of grafting her other knee. So I don't think we have any questions in the chat here, so I'll pass it on here.
Neil, I was just going to ask real quick, unless somebody else has a question. I think these ones are really hard. Like the 40s-year-old, kind of category is just, it's a challenging group, right? Because like this lady is not somebody who is going to want to do a total knee, and yet she has a multifocal defect. So how do you have that conversation with them about preservation versus, I think sometimes people get scared away by multiple defects and just say, look, there's nothing I can do to help you, or you need to do a total knee. And it may not be a huge number of patients, but my practice similar to yours, like you see a number of these people in their 40s that are in that kind of weird middle zone. And I think some of them really are very good candidates for cartilage restoration. So how do you kind of navigate that when it's a challenging situation like that?
Yeah, I mean, you're exactly right, man. Like, right now, there isn't a tried and true, right? And I think you kind of started the question with the answer, which is, what else do we have available to us? By the time they've gotten to this type of talk, they've done all the things we would typically expect, right? They've done their PT, they've done their offloading brace, they've done their injections. They're very young, they're very active, and they've got a problem. And so then the question we have to ask the patient is, very simply, can you modify your life enough that your knee can handle your new load? And, for a decent percentage of patients, they can change some things, right? Maybe they were a runner and now they become something else, so they just run less, or they change some of their life. But there is a segment of patients that no matter how much they try to change, they just have functional loss and pain that even kind of basic things give them issues. And I think for young patients, even with multifocal disease, this can be a really good option to say, hey, listen, this has the ability to get you, obviously we would like all outcomes like this patient, right? But really the ability to get back a significant portion of their life that they kind of thought was gone forever, right? And then kind of long-term, obviously, how to manage that improvement to maintain that for as long as possible.
Neil, I have a question. It's Ira. If I was scoping this, and I like to say I identify as a hip and knee surgeon. You see this, and you really think the knee is gone. And wouldn't you agree that most surgeons who don't know about the option that you offered this patient would have just done the scope, maybe done some microfracture drilling, and just told the patient, you need a total knee. I mean, this is just such a remarkable example of knee preservation. But you know, so many people would open up a 40-year-old and say, you know, we're done. I mean,
Yeah. Yeah, no, you're right. I mean, and that's honestly one of the reasons why she came to see me in the first place, right? Is that my partner just, wasn't sure about options. And honestly, I think, Matt Ryan can kind of chime in here that just what we know about sports medicine, going forward, we're seeing more patients who are younger, early mid 30s, late 30s, early 40s, who even have had previous trauma, right? ACLs, meniscus work, so on, and are starting to show signs of post-traumatic osteoarthritis, which, not necessarily isolated to just one defect. And the question is, what to do. A total knee in a patient this young comes with a lot of issues, which we know about, right? And that's not a perfect option. And I think that's kind of a conversation that, and I've had this conversation with my joint colleague, or joint replacement colleagues, to say, how significant are those issues? We know that, right? Doing a total knee in a 45-year-old comes with some serious issues, not just short term but long term. And say, like, okay, what's more at risk here, right? And I think this technology has some outstanding data for patients who previously we thought we were stuck. And I think, in my hands, in my experience, that's probably one of the biggest things when it comes to using MACI for my patients, is really just understanding it provides a good option, an option with data for patients like Dr. K, you were saying, who we previously thought didn't have a chance.
yeah, great answer.
Before we pivot into my case, I was just going to ask two questions that kind of came up that I wanted to kind of get both Dr. Tao and Dr. Kumar's thoughts on. But both of you mentioned staging scope, and I guess as we do more and more of this surgery and see more and more of these patients, I wanted to get your guys' opinion or kind of share it with the audience as far as, do you typically do that with the idea of, hey, we're going to get inside, we're going to debride the lesion and kind of see what the options are and see how you do, versus how often are you committing to, hey, we're doing this and then we will be coming back, 8 weeks later, whatnot. Because I feel as though the more of these I've done, I kind of hedge a little bit and say, hey, let's get in, let's kind of see what's going on, debride it, see how you respond to that first surgery, get them, 6 to 8 weeks down the road, and try to kind of start to incorporate them back into things and see where they're at. And, it seems like they kind of self-select with regards to who's going to go on to need further intervention. And just wanted to get your thoughts.
Yeah, I think that's totally true, Fates. I mean, I take that approach too. I mean, there's certainly some where I'm going in saying I'm planning for this to be staged, but I mean, I'll use a case today as an example. I have a girl who's probably in her maybe early to mid 20s, out of college basketball now, but played collegiate athletics for several years and has patellar defects on both sides. One side bothered her more than the other, and I scoped it maybe 6 months ago with the intent of, probably we're going to need to do some cartilage restoration here. We talked about MACI, took a biopsy. I think the data from MACI is the strongest in the patellofemoral joint. The data is the strongest for MACI far and away. But she got in that range, like you said, 6 to 8 weeks. I mean, and was like, honestly, I feel great right now. So I said, well, that's fine. We can just watch it. Like, I love doing this surgery, but I only want to do it if we need it. And the beautiful thing about this is we took the biopsy. We know the defect. If you need it down the road, we have 5 years and we can use it down the road. So anyway, so I just scoped her other knee today. So we'll see. Looks like we have a couple questions in the chat. Dr. K, you want us to go through those?
Yeah, Jeff Watts, you want to ask your question first? Jeff, you want to undo your mute and ask your question directly?
Yeah, appreciate it. Thanks for accepting my question. So I saw, Dr. Kumar, one of your arthroscopic, I guess, intra-op images showed the cartilage lesions was along the median ridge of the patella. So I'm just trying to picture in my head with the guides that you use to cut the kind of cut out the cartilage. Are you kind of levering that one way or the other? Or are you just pushing that straight down just because it's not your typical flat surface, kind of like the condyles or tibias more classically are? Just wondering, like, technical pearls for that, I guess.
Yeah, it's a great question. So Yeah, and almost like you said, we almost rock it. So obviously centering it over the defect and just being able to kind of rock your hand. You can still use the cutter; it fits great, and just kind of that just little tilt back and forth. Sometimes what I'll do is take a little mallet, and obviously we don't want to fracture the subchondral bone, but as we rock it, kind of score the cartilage that way. What also helps sometimes with the cutter on the cartilage surface, which works for defects on any part of the knee. I'll actually leave the cutter on the surface, and with that kind of metal ring, either take a scalpel or a curette and score the cartilage there, and that helps me really be able to identify obviously the sharp borders. It makes clearing out the diseased cartilage a lot easier, and especially on those uneven surfaces. Trochlea, kind of the same idea. Much faster, much easier. But you can absolutely use the cutters with that just a simple technique, and it works great.
There's another
Great, thank
question
you.
from Michael Meyer. Mike, you want to unmute? Well, while Mike's unmuting, I'll ask his questions. Do you have a BMI cutoff for combo procedure like this in a more non-compliant athletic population, if any?
I usually you will say BMI of 35. I think generally speaking, that is a number that shows up a lot in the literature for various things. And that's just what I use. I don't know if Matt and Ryan, if you have anything different.
I'm kind of right in that same ballpark.
Yeah, same for me, especially for a condyle. I don't really like to go over 35. I will make an exception sometimes for the patellofemoral joint. I think it sometimes is a little bit more forgiving in that regard, just since it's not the weight-bearing part of the joint. But in general, I do try to tell them 35, and sometimes it's also just a motivation to lose weight, so that can be helpful too.
Excellent. Marty Nichols, you had a question about the alignment, which I
Sure,
think.
Dr. Tao, you said that you take a AP and you look at for the mechanical alignment. Is there a mechanical alignment or a range that you see that you wouldn't do this procedure on? And then if there was, would you do an osteotomy first and then do the procedure?
Yeah, great. I mean, honestly, great lead into Ryan's case, Marty. Thank you for that. I think the alignment is really, really important. It's interesting because I feel like even in the last 2 years at the national meetings, the talk on osteotomies has gone way up, which I think is good. I think we have to be a little bit careful on not saying everybody needs an osteotomy. There's no big deal. I mean, I have my own complications. I just had a girl last week who fractured through her TTO. So, but I do like them. I think they are really, really powerful, both in the tibiofemoral and the patellofemoral joint. So I don't necessarily have a cutoff of when I say I won't do cartilage, but I will say my threshold to do an osteotomy is pretty low because I think the osteotomy helps quite a bit. There's definitely some data. I think it was either Dave Flanagan or Seth Sherman had a paper a couple years back in the patellofemoral joint, just saying that cartilage with osteotomy does better than cartilage without. And I think same is true for the the tibiofemoral joint. If they happen to be in, say, even 5 degrees of varus, whether you're doing MACI or an OCA or whatever, correcting that varus is going to be not only a powerful way of improving the biologic environment for healing in that first 6 to 12 months, but also really offloading that joint in the future and hopefully preserving it longer. So it doesn't mean you always have to do it. I know some people are not super comfortable with osteotomies. I hope that continues to get better as maybe the education improves and this generation of surgeons and the younger generations of surgeons see them again, because I think that just hasn't been true for a couple decades. And PSI, as Ryan's case will show, may be a helpful way to do that. But it's a great point. I think the alignment matters a lot, and I think osteotomies can be a really powerful tool, either in isolation or often in conjunction with cartilage restoration.
Yeah, I agree with that answer, Dr. Tao. And I think so. If you're not doing osteotomy, I guess if you had to make up a number of how much varus or how much valgus is too much before or to allow you to do an isolated cartilage procedure, I'd probably put it at the 5 or 6 degree mark, or anything beyond that. If you're in a ton more varus or valgus than that, I would not personally recommend doing an isolated cartilage procedure, especially something that's cellular based.
All right, Ryan, you're up for your case.
All right. Well, go a little different direction here. So this is an 18-year-old high school soccer player that presented to my clinic, referred from another part of the state that had one or two prior lateral meniscectomies, and then otherwise had just kind of been managed conservatively for persistent lateral knee pain, swelling, and it just really was progressive over the course of just over a year, where he basically became disabled from being able to play soccer, started to develop more daily symptoms of swelling, catching, and pain on that lateral side. And so he presented to my clinic with um, imaging, and like Dr. Tao mentioned, I'm gonna have you go one slide here forward if you can, Dr. K. Um, which we'll get into here in just a second. But this patient, very clinically, you can see he was in a little bit of valgus, had a mild effusion, normal range of motion, normal ligamentous exam, and as I mentioned, previous knee scope surgery. He had normal joint space, obviously, as you'd expect in an 18-year-old. And like Dr. Tao mentioned, I do routinely, especially in the tibiofemoral joint, obtain standing X-rays to look at the alignment. Um, and we'll show those here on the next slide. And you'll also see his MRI results, which demonstrated a full thickness cartilage lesion of his lateral condyle. So looking at his 18 lateral X-ray, not a whole lot to comment on there. Young kid. You can see his genu valgum on the right side, which measured at approximately 6 degrees, and neutral alignment on his contralateral left side. A couple of MRI slices here, sequences that measured approximately 17 millimeters of a full thickness lesion, with what looks like maybe even some very early and subtle subchondral change, lateral femoral condyle, and a mild amount of meniscal deficiency, which you cannot really appreciate on these slices. So meniscus status is one thing I wanted to talk about, because this is a little bit of an interesting case where you got, I think, all the knee surgeons in the call can kind of recognize this spiraling pattern that we sometimes see in these younger patients that have lateral compartment surgery, where whether they have a discoid meniscus or unfortunately have some sort of traumatic tear to the lateral meniscus, there's kind of this downward spiraling where they kind of get a repair and it maybe fails, and they end up with a meniscectomy, and then they end up with the cartilage lesion, genu valgum, and this kind of starts to happen. And so I look at this as kind of a three-pronged problem here in this kid. This is a kid that not only has, not amazing lateral meniscus and maybe he's a little meniscal deficient, but subsequently now has overload of his lateral compartment. He's in valgus and has a cartilage injury. And so, I think all three of those factors need to be kind of considered when you're looking at your treatment algorithm and kind of what you're going to do with them. I did have this kid do a little physical therapy to strengthen up for believe a couple of months, and threw him into a lateral unloader brace just to kind of see where we could get him to. Obviously, it really restricted him physically with playing soccer, but just kind of on a daily basis, he did notice some improvement in his pain, and was able to kind of just walk around and be normal without a ton of lateral pain. But the second he took the brace off, he was again having pain and symptoms. So ultimately, with a kid like this, we decided, his goal was to return to high level soccer. When looking at those three problems and which of the controllable variables we can control or kind of address now, I look at it and say, hey, I think this is a situation where we normalize your mechanics with an osteotomy. We restore the cartilage with a cellular-based surface procedure like MACI, and kind of punt or defer on the meniscal transplant for the time being, knowing and having a very, very candid conversation with the patient and their parents regarding, hey, meniscus allografts, meniscal allografts don't really hold up from the apparent, from our current literature with high impact sports, cutting and pivoting. And so we don't want to kind of shoot all our shots right now and just try to get you some relief and try to, give you your best chance of getting back to sports right now. So I had a very candid conversation and, initially proceeded to the operating room for a staging scope. I know that he had prior surgeries, but I really wanted to evaluate this lesion. The MRI typically, as we all know, underappreciates the size and extent of these lesions. And so I was able to get in there, take a look at this condylar lesion myself, evaluate his meniscus, which I approximated was probably, 35-40% left. But otherwise the knee was normal on the staging scope. So measured the defect, a little over 15, 16 millimeters in size, 2 or 3 millimeters deep. And again, just like we had discussed earlier, try to see how he could do with some strengthening post-operatively and just some of that cartilage debridement. Unfortunately, the kid continued to have pain and symptoms. And ultimately, we decided to proceed to the operating room with MACI to his lateral femoral condyle and distal femoral osteotomy using patient-specific instrumentation. So did obtain a CT scan as well to assist with this osteotomy. And again, we kind of reiterated that conversation with the meniscal allograft and said, hey, I think this is a situation where this isn't maybe the complete solution for right now, but probably the best answer for where you're at right now. And this is a situation, Dr. Tao and I discuss this all the time, probably talk almost on a daily basis about different cases and different cartilage stuff and get nerdy, but where I think MACI really can shine. And that is, I think with our younger patients, we're starting to use it more and more. I do not do any microfracture really at all anymore in my practice. And I would say I lean towards chondroplasty and then, if needed, a MACI procedure. And I really like that it doesn't burn as many bridges. It's, backed with literature and very customizable. And I think it's, very diverse in its application in different areas of the knee. So I thought this was the perfect case for a young kid. So intraoperatively here, you can see just the post-debridement pictures on the left, and then after the membrane was applied. And I do want to kind of comment here in the order of operation, because I think I do this backwards, in MACI procedures versus osteochondral allografts, where I had one today actually that needed a high tibial osteotomy and an osteochondral allograft to the condyle because of prior cartilage surgery that had been performed. And in those situations, I like to do the cartilage first because the grafts are very structural, get it in there, and then I can feel very confident and comfortable with bending the knee or doing whatever I need to do for the osteotomy for positioning. I actually believe personally, in my experience, is that I feel like it's easier to go the opposite direction in MACI just because of the membrane nature of this surgery. And so in him, we started with it kind of an extensile lateral approach as you typically would with a DFO procedure, and then made a little step cut in the IT band, and we're able to extend with that same skin incision this into kind of a mini lateral arthrotomy and really get a lot of mobilization, of the patella and get it out of the way here. So it gave us a really great view of the condyle, and you can see the membrane there in place afterwards. I again used one of the templated instruments for sizing. I would say that 90%, 95% of the implants that I place are usually within kind of the general vicinity of one of those templates. I think they did a great job with instrumentation and design, and really, really speeds up the process. Matt, I also have had, those specific lesions. I find them typically more so in the trochlea, sometimes in the patella. Although Dr. Kumar described exactly what I'll do if I do use a prefabricated or defined template from this set, which is to kind of do that rocking maneuver he mentioned, and then kind of bury the putter and just kind of to scrape out the cartilage kind of within it to define your boundaries a little bit better. So that's what I did for this lesion. And you can see on the next slide here, just the osteotomy and the change in alignment here. So we took him from about 6 degrees of genu-valgum to a slight overcorrection over his medial tibial spine, just to offload and kind of accentuate that offloading of the lateral compartment given his meniscal status. And this was him at, I think, approximately 9 months post-operatively. Has done extremely well, as they all do, right, in these cases that we present. But truthfully, this kid has done awesome. He's back running. He's been training. Now he's just about a year out and is fully incorporating back into team practice and his academy soccer again. So, I think this might not be the end of the story for this kid for the rest of his life, but I think this should really, restore his function for right now and allow him to do what he wants to do. And certainly there may be bridges to cross down the road, but I'm very thankful for Macy and the technology that we have with this surgery for patients like this.
Fades, maybe
I think
I'll
we're
go back and just ask you about the decision for kids, and Neil, maybe your opinion too. Like, I think it's a really good point. I mean, all three of us use multiple products. This is not meant to come across that we're only just mouthpieces for Vericel, that we only do Macy. I think, as Ryan said, there's been a long history of data. We know that especially in the cartilage world, there's a lot of things that don't have data. And so I think we feel very good about using that because of the history of data, and it does work. But we certainly use other products too. So maybe, Neil, can I ask you, like, what's your thought on cartilage in young people? I know off-label under 18, although probably most of us have done that still too. I think I share some of what Ryan says. Like, I certainly do and have used osteochondral allografts in young people, but especially in bigger defects, I do worry about just the biologic side of it, that if that doesn't heal, you're in a really bad spot. So having something like Macy where it's cell-based, it's autologous, I think I've moved that way more the last few years. I don't know what you think about that.
Yeah, I would second that 100%. I mean, I think for a couple of reasons. Number one, especially in our younger patients, love autologous tissue, right? So not just autologous cells, but autologous bone. And so, when I do an osteochondral allograft, reaming out all that bone. Now, obviously, most of that's going to be disease, but doing it in a younger patient, be able to keep all that autologous bone, the subchondral bone, just makes me feel better in terms of being able to get this repair to heal, but also preserve. Right? That's like the big thing, because 10 years for an 18-year-old is very different than 10 years to a 38-year-old. So really trying to give them the best chance in terms of autologous tissue. So that's one. And kind of what you said, what happens if something fails? As surgeons, we always want to have a plan A, plan B, and also what happens if it doesn't work, And again, having a large defect, not just of cartilage, but now of bone, an osteochondral allograft adds a completely different layer of challenge, should something, occur. That's also one of the reasons why I agree with Dr. Fader. I don't microfracture anymore, because the data continues to show unfavorable outcomes if that fails, durability issues, and then burning bridges. And so, and I think, again, it's just a compromise of that autologous bone and subchondral plate. So I agree with you. I've really started to shift more, not abandoning OCA, but more to Macy, especially in a younger patient.
Do either of you have kind of a cutoff? And I'm asking this. I do not, but I just I've kind of been thinking about this more lately as I've started to lean more towards Macy in younger patients. It's just like, is there that cutoff where I say, you know what, this is one that I'm gonna lean towards osteochondral allograft? And I do think there's a lot more that goes in decision making than just age. I think it really depends on the morphology of the lesion, the subchondral involvement, kind of other stuff going on. But it is kind of an interesting discussion.
Yeah, I think that stuff I think is super relevant, Fades, like of just kind of taking each of these individually. And that's where I think cartilage, I was just talking about this with one of our students earlier this week, that I think some people just don't like cartilage surgery because of that there's a lot of gray, as Neil mentioned at the beginning. There's not a clearly defined algorithm. You may have trained at a place where either you didn't do cartilage, or you only did, whatever, you only did microfracture, you only did OCA. So it doesn't feel like you have a good understanding of everything. And so I think that stuff is relevant, though. Like, is it somebody that's going to be, willing to do the rehab like we talked about at the beginning? Is it something where there's cystic changes in the bone? Certainly, you and I have both had ones where we do a sandwich technique where you address the bone and bone graft and all that, but there may be one where you just feel better about that time zero stability of an OCA. And I think that's okay too, especially if it's something like Marty was asking earlier with, maybe they have some, say 4 degrees or 5 degrees of malalignment. You really don't want to do an osteotomy, or they don't want to do an osteotomy. Maybe you feel better about doing something structural like an OCA. And I think that's okay. I don't know that there's a right answer with that, but.
No. So this is phenomenal stuff. We are, as I like to say, the fastest hour in orthopedics. Um, I would like each of the, of course, thank everybody, but I want to ask each of the panelists to sum up a little bit about and talk a little bit about the concept of the opportunity this gives orthopedic surgeons now that it's hopefully becoming much more mainstream. But just a little summary of the Macy mini-arthrotomy or Macy arthro technique. We'll start with Neil, we'll go to Ryan, and we'll have Matt bring us home. Neil, some comments, some final comments?
Yeah, I mean, I think this technology, I think pretty clearly the data has shown over long-term durability, excellent outcomes, and I think with Macy Arthro adds just another factor to make cartilage repair accessible to everyone, where it's no longer has to feel like a black box. And I think we're going to see that, going forward, as especially again Macy Arthro continues to show outstanding outcomes and reduced downtime and easier post-op recovery. That it's something that we can offer our patients and feel much more comfortable about that outcome.
Okay, Ryan?
Yeah, I mean, I think it's an extremely exciting and versatile tool that we have in our toolbox. Like Matt mentioned, it's not a one size fits all procedure, but it's an extremely versatile procedure. Allows us to access multiple parts of the knee and the literature that backs it up. And I think I'm very excited to see kind of where things go with the arthro component here, because I do think that although that maybe doesn't speed up the biology of the procedure and the healing of the cartilage, I do think it can really limit morbidity and kind of get those patients going earlier, and do well on the earlier side of the recovery. So very exciting, and I love the minimally invasive direction that we're headed.
Excellent. And Matt, you want to bring us home for tonight?
Yeah, well, I would just thank you, Dr. K, for hosting this. This is a great event. 100 some people on here. It's awesome. And this doesn't have to be the end of the conversation. I think one of the things that each of the three of us really like is the education side of it. And so, feel free to ask questions. Talk to your local reps. They're a great resource. One of the neat things about Vericells is a pretty small company, and so the reps know each other. The surgeons that work with them, we're happy to talk. I mean, I'm certainly happy to review cases if you guys want to reach out. We'll be at AOSSM, a lot of us as well, if you want to stop by the booth or ask questions or even do training sessions and all that. But it's just a neat thing. I know it is kind of a black box sometimes for people, but it really is a powerful way, as Neil's case demonstrated beautifully, of just improving pain and function and prolonging the need for arthroplasty down the road. By no means is every case a success, but it is just a really, really neat thing in terms of trying to think through thoughtfully the cartilage and some of the other factors that we talked about, whether it's Macy or something else, and just trying to identify who are the patients where preservation may meet their goals and where you think it makes sense. So I think arthro is an exciting development with that too. Certainly encourage you to play with the instruments with your rep or at one of the meetings. And as I said, if you want to at any point, just reach out and let us know. Always happy to help review cases and chat about things.
Well, this has been a phenomenal evening. I want to thank Vericel for their work in helping organize this and for sponsoring the evening, and the Joey team for working on it, and of course our amazing panelists, Neil, Ryan, and Matt. Thank you very much, and I want everyone to have a good night.